So we're going to start with the live case from the second affiliate hospital of Zhejiang University in China. And Dr. Wang will be the operator. He's the professor there and has been really a pioneer of TAVR procedures in China. He's going to talk about, I think this case is going to be bicuspid valve, I think, Dr. Wang.
Hi, yes,
Hi,
Professor
how are you?
Yang.
Hi.
Nice to hear you, but I have not seen you yet. Okay,
Yeah.
I'm wearing a glove. No?
Yeah, thank you.
So, thank you, Professor Yang and Professor Hong and all of faculties. I'm so honored to have you join our live demo session, transmitted from our side, the second affiliate hospital, Zhejiang University School of Medicine. So first, please allow me to introduce my colleague.
Hello.
Okay. Next to me, I think you're supposed to know him quite well, Dr. Liu.
Hello.
And
Hello.
that's him is Dr. Wang. Also today we have an anesthesiologist. Who is an anesthesiologist? Okay. Anesthesiologist there and echocardiographer over there. Okay, can you see us?
Yes, very good. Yeah.
So sorry, we cannot see the conference room. Oh, okay, now it's fine.
Oh,
Also, Professor Wu Yongjian
yes.
from Fuwei Hospital.
He's online from Fuwei Hospital, right?
Yes.
So.
Okay. So first, I invite Dr. Liu to introduce the case. Dr. Liu, please.
Okay. 切换到幻灯片. Okay, dear panelists, it's very honored to present the case right here. And the patient is the 70 years old lady, has the recurrent exertional dyspnea for 1 year, and the patient has a history of hyperlipidemia and a history of COPD. Next one. And from the echo, we can see very severe aortic stenosis with enlarged the left ventricle and the low LVEF, and with the moderate AR and moderate MR. Next one. And then we check the CT scan for the patient. The coronary looks good right here. Next one. And from the CT, we can see the aortic root. Right here, we can see the parameter of the aortic annulus is about 80 millimeter, and the parameter derived diameter is 25.3 millimeter. And we can see the very severe calcification and the type 1 bicuspid aortic valve, and the very thickening of the leaflet. And we can just see the fusion from the left coronary sinus and the right coronary sinus. Next one. And the coronary height is good. Next one. And we can see right here very severe calcification and the extension to the LVOT. Next one. And the access looks good for the patient. Next one. So the summary of the case is very severe aortic stenosis, and the STS score is about 6.6% mortality, and the bicuspid type 1 aortic valve, and a very heavy calcification, and the calcification extension to the LVOT. So the procedural strategy, and from the heart team discussion, the TAVR is suggested from our team, and we will use the venous A plus valve. And for the size, we will use the Hanzo solution, the supraannular structure-based sizing strategy. Next one. And this is the protocol of the Hanzo solution. And we, according to the CT scan, because of the parameter-derived diameter is 25.3 millimeter. So this is between 23 to 26. So we will use the 23 millimeter balloon to the balloon sizing. And if we see very clear waist and with no regurgitation, and then we will downsize twice of the valve, and we will use the 26. If the other three there's no waist or with the regurgitation, And then we will use the annulus-based sizing strategy with the 29 millimeter.
Supraannular.
Yeah.
Supraannular sizing strategy.
Yeah.
So we use we call the single size balloon sizing strategy or supraannular sizing.
Yeah. Okay, next one. And I think all of you is very familiar with the Venus A plus system. And the Venus A is with the very strong radial force, so specially designed for the bicuspid and severe calcification. And Professor Wang and leading our team and the engineers to develop the second generation to move to make it the retrievable and repositionable for the valve. Okay, that's all. Thanks.
Thank you. Maybe we could ask the panelists if they don't have the Venus A plus, what would you use in your own country, or so maybe a quick discussion.
Okay.
Yes, and yes, the Professor Wang is. This is, I think, a very nice and challenging case. So, and could you? Okay, I'm DW Park. Yes, could you briefly comment on what is the main difference of a Venus A plus versus and the conventionally used Evolut R system?
Actually, the Venus A plus is developed on the same platform as the Venus A.
Yeah.
So the Venus A has a very strong radial force, and especially very good for the bicuspid or very severe calcified leaflets. So based on the Venus A platform, we try to develop it into the retrievable device. So it's a little bit different from the Evolut Pro. The Evolut Pro, I think the radial force is not so strong as the Venus A. Yeah, but it's not so easy, the so strong radial force. We will make it becoming a retrievable. So it's a little bit tough for the designing and for the manufacture.
Transmission. So maybe while they're fixing that, will you use a balloon expandable or a self-expanding in Asan if you have the same patient?
Yes, so I think it's depending on just like a very severe calcified region. If you select Evolut system, sometimes the full expansion is difficult. So, and the much preferred valve system is Sapien valve, even though there would be some severe calcified region.
Mm-hmm. You're right. So
I can hear it. So, okay. So
okay.
Okay.
Actually, I agree with this patient in the clinical aspect. This patient is a really high-risk patient. First one is the bicuspid. Second one is a heavy calcific. It means the procedural success or perfectiveness might be lower, and after the TAVR valve deployment, there is some more risk of the complication and the not concentric, eccentric, and there is a more risk of the paravalvular leakage. And finally, in his presentation, I found that there is some extension of the calcium in the LVOT outflow tract. So when we use the balloon expandable valve in this patient, there is a risk of the perforation. So we have to be cautious. So personally, I think in this patient, in the aspect of the operator, I'd like to the procedure with a more safe mind is a more comfortable situation. So personally, if the patient is my patient, I select the self-expandable valve. And another question is I'd like to ask the patient height. What I mean is actually the annulus of this patient looks small. Is one of the typical feature of the Asian patient. Small size of annulus. Why small size of the annulus? The reason why body performance itself is smaller. So I'd like to ask the height of this patient, maybe less than 150, small size of the patient.
How height is the patient?
155.
155.
So just barely 5 foot.
It's a regular size for female in China.
That is the Asian side, not European or the Western side.
Sure, sure.
So one quick question, Doctor. And you said you have greater, obviously strength in the venous A valve. Do you know by how much? Is it 25%, 50% in terms of the ability to distend the valve, the nitinol frame? Is that you right? I think you cut off again. So I think that'll be interesting. How much indeed, right? 10%, 20%, 50%, but I don't know.
Maybe for the bicuspid stenosis patient, I think that for most of the patients with a severe calcification, I don't think the fully expanded rate is about 60%.
Yeah.
How do you say? Fully expanded rate. It's about half now. What kind of for those patients with the cusp, especially zero with very severe leaflets, maybe the fully expanded half and half.
Okay. Maybe let you go ahead and do the procedure. Maybe the transmission.
Okay, I just feel we already go through the effects of the valve. So now we.
The video is not syncing. So.
The signal is not good.
Yeah, I think the.
Yeah, so maybe the Professor Wang can go to the procedure. So I'm Dr. Wu.
Hi,
so
Dr. Wu. Yes.
Yeah, hello. Hi. How are you?
So we get a sheath in, then we did the angiogram. You can see the patient has a stenosis, also with the regurgitation.
This is the cause
The
of
severe regurgitation. So you can see here very clear the calcification is very severe.
Can we
So then we go
see
through-
Dr. Wang's transmission?
You cannot see our image.
Yes.
You cannot see the flow.
Yes.
Okay.
Wait
can you see the
a
flow now?
second. Yes.
Dr. Wu, do you think you can turn off your video? Maybe it will help the bandwidth of transmission a bit. Just stay on sound but no video from you. So maybe from China that might be some bandwidth issue.
王院长，你那个信号确实不是特别好，王院长。
信号看看外面转播公司。
你那个信
你要
号。
跟转播公司说，转播公司很有问题啊，是那个呢
今。天这个转播不是不是咱们的转播的那个公司吗？
是我们自己的吴主任。
哦，对，那个信号确实不是非常好的这个。
现在看得到吗，吴主任？
我现在看的你那个是大部分就跟动画片那个样子似的，就是。
I don't understand what they say. Yeah, but I think
They're saying that it is a still picture from their end as well. So we have a still picture. We don't see any
Yeah,
motion.
so the picture is not moving. It's the dust.
Yeah.
okay.
But the voice, so your voice is clear, but the picture is not moving.
I think it's better to choose self-expandable THV in this case, especially. I think on the left ventricular outflow tract, calcium is the most dangerous thing to use the balloon expandable valve here. But in this patient, the age is very young, and also the pressure range is very high. So it is very important to choose which size of stent is suitable for this patient, because in the flow sheet, they showed us aperture balloon valvuloplasty, and then decide what size of stent should be chosen. Because if in case of very severe aortic regurgitation after the pre-dilatation, there's no time to choose. So I think it's better to choose balloon size, THV size, before the balloon
Yeah.
valvuloplasty.
So since the video transmission is good, we let you do the procedure in case it's still again. Go ahead, Dr. Wang. Just go ahead and do the procedure.
Hi, sorry, the transmission is temporarily interrupted. So now we can say, so after the angiogram, you see the patient, also the patient has a severe regurgitation besides the stenosis. So we can see now we get the picture in the left ventricle, go through successfully. Then now we measure the pressure gradient. Can you see the hemodynamic screen?
Yes.
Okay.
Yeah.
Okay, the pressure gradient is very big.
180.
180, almost 200. So it's a very typical hemodynamic sign for patients with bicuspid aortic valve stenosis patient. So now we are try to put the Y in, then we are going to do the balloon sizing, the balloon valvotomy. So now we get one of the panelists have asked just now asked the question whether the balloon expandable device is better than the self-expanding. Actually, until now, we don't have research evidence to support which one is good for bicuspid. You know, we know the expandable device has a very good radial force.
So I think it's another issue. It depends on the experiments of the operators. The Professor Wang, his team has more experiments about venous A. I think for this case, he has a lot of experiments with the venous A pass. So it depends on the.
The regularly, you know, the actually very important for this kind of patient, we need to evaluate the size of supraannular structure. The balloon expandable device is comparable with self-expanding. The balloon expandable device is quite short. So for some patient, the device may not cover the supraannular leaflet enough. The other problem is balloon expandable device, the radial force is too strong. For this kind of patient with severe calcification, especially with the annular calcification, may cause the perforation of the annular. Has a high tendency to cause the perforation of the annular.
So, this is a 23 millimeter balloon?
23.
Yes.
Yes. Now we use the single balloon size strategy to do the valvotomy. Just we select a size of balloon, select a size of balloon close to the annular. Just one time the valvotomy. Okay, start pacing 是起波180。
起波了。打在一起。
平起波，
所以是1的。
平起波。
OK。
So we don't need to the second balloon dilatation. We don't need. Just a single balloon valvotomy is enough.
Yeah. So Professor Wang, so maybe one question for you, and so because so because the bicuspid is not so because this is the bicuspid, so maybe you can use the biplane and to check the balloon is totally open or not.
Okay. 这病人有点那个加大一点麻药好吗？
哦，这个是局麻的吗？这个是？
Yeah, the patient's moving a little bit. Yeah.
We give a little bit venous sedation.
Let me ask the size of the ascending aorta during the predilation. The aortogram looks like the size of the ascending aorta a little bit bigger. What I mean is in the disease of the bicuspid valve is actually not the degenerative, it's the vasculopathy. So we have to be always some caution in some injury of the ascending aorta may be related with a very catastrophic event. So
I fully agree with you. Keeping the ascending aorta safe. By the way, how big is the size of the
44.
44? So usually if the patient has 5 millimeter or above, we
actually in my eyes it's more than a five. So that is the reason why I ask you about it. Okay.
Yeah. If you index to her BSA, probably large.
So the Professor Wang, so I will.
永健说的他那个平面哪个平面照比较清楚？
So Professor Wang, maybe not. So and from the balloon sizing, so it's no the rectation and it's totally the open, no waste. So do you want to select 29 or 26?
I think the patient, the balloon still has a little waist size without the regurgitation.
Mm-hmm. So maybe 20.
I think the 26 should be big enough.
Yeah.
What is about the size of annulus? Annulus is 25.
25.3.
And now the balloon size is 23.
Yes.
I think the 26 should be big enough.
Okay.
Regularly we downsize one scale. So the Venus A plus the scale system is similar to it's exactly the same as the Venus A. So 23 is the smallest one, then one scale up 26, then 29, then the biggest one is 32, right?
Yeah.
So 23, 26, 29, and 32. So what is the Professor Wu? What is your comment? And what is the panelists' comments?
Yeah.
On the stage?
I think
what is your suggestion? How big size?
I think you have the most experiments about the Venus A plus. So I think according to the Hangzhou solution, maybe 26 is enough. But I think from the balloon sizing, because the no rectation and also the very small waist, I think 26 is maybe okay. And if you downsize to 26, maybe the high position. And another the problem is the quantification extend to ROVT. So I'm afraid. So if you use the 29, maybe the valve should be the deeper and to cover all the calcified tissue.
Yeah.
All right. The 26 maybe go for the higher deployment. Now also go for because as you know, you mentioned about the sinus size is quite small.
Yeah.
So 26 maybe also go for protecting the
26
from the artery.
Yeah, sinus are kind of effaced,
Okay.
Yes,
Okay.
I also agree with the sizing of the THV26 may be good, but I'm not very familiar with the Venus A system. So, how high the radial force is compared to the other self-expandable valve. So, first question is there is a trade-off the radial force to seal up all the paravalvular leakage by the higher radial force self-expandable THV, and also is there any permanent pacemaker implantation rate because of the always trade-off the parallel lead and then pacemaker implantation? And the second question is after the balloon angioplasty, the calcium was broken and then the calcified valve maybe directed to the left coronary ostium. Is there any the risk of the left coronary obstruction with this kind of valve?
它是
Okay.
体膜气直流率，就是我
Actually, since we apply the Hangzhou solution, the average pacemaker implantation rate is around 8%. Around 8%.
Okay.
So
So Dr. Wang, you're preparing a 26 to
yes,
go
we're
ahead.
going to
Yeah.
prepare.
OK
Okay, 26.
带我来
Get ready?
Yes
第二个问题是那个
coronary 的问题
coronary.
冠脉其实你看
Actually,
先好
you can see that why we need the balloon valvotomy. So two purpose. The one purpose is to try to three purpose. One purpose is to try to open the orifice of the valve. The second purpose is to sizing the supraannular size. The third purpose is to see whether during inflation of the balloon, whether the orifice of a coronary artery is occluded or not. So from the patient, you can see when we do the angiogram, the left coronary orifice is totally open.
Yeah.
It's far away, the balloon is far away the orifice of left main coronary. So don't worry about the left main. But because from the CT scan, we already know the orifice of right coronary artery is very high. So we don't have any concern about the occlusion of coronary artery. So the third purpose, the three purposes. So now we get the device in, the venous A plus.
看一下导师
So we need to take care of, or maybe we need to adjustment of the wire.
What wire do you use for the venous A plus? What wire?
Lanoquist
Longquest.
Lanoquist?
Longquest, actually, in China, Longquest is the only available wire. Yeah, commercial available wire. So, but you have to take care of the wire, you know.
Yeah, be careful. Yeah, extra careful. Yeah.
In our early practice, we have one or two cases. The wire caused the perforation of the ventricle.
打扰了好
就升压药，
好
差不多了，
我们再下去聊再下去
没过。
OK 好好打回到那个 cusp overlap
We go back to we need a cusp overlap view. 你升压药，你这不知道是不是在这个里面？
它这个是在豌豆
So you need it in the non-coronary cuts as well, right?
Very hard to manage.
Yeah.
Personally, I think this is not a good view for the procedure. The reason why valve was the overlapped the other caster,
实来操作一下。
so we need a more separated, clear target view.
You should try to get into the non-coronary. Yeah, go.
Maybe we need a wire.
That's good. Yeah, you got it. Yeah.
再冒个烟嘛。The blood pressure is dropping a little bit, but now it's going back. So we need to take care of the blood pressure.
Yeah.
Let me do an angiogram to see whether the pigtail is sitting well or not. 就这样吧。
好的钙化可以看得到
挡住了。
好
Okay. So regularly we target the 3 millimeter, 1 to 3 millimeter lower than the annular. So for this kind of patient, maybe
钙化可能是对体验
可能还要再下一点。 那就要不要再下一点？
啊，还会往下降。
啊，这里可以。
Okay.
So the bottom of non-coronary sinus maybe just in the lowest calcifier. Yeah, 差不多。Still a little bit low. We need a little bit high. Okay.
对，我们就
差不多。
看该换了。
Start pacing 130 beats per minute. 130次起搏。Are you sure it's the cusp overlap? Okay, good.
这个我们调过了。啊，起搏。
So now we start pacing 130 beats per minute, and keep on going to release the device. Keep on going. Keep on going. Okay, stop pacing. Because the patient has waist with. So what do you think? The position is too high, or do you think it's okay? It's almost zero, and even a little bit above zero.
Can we check an LAO view and also do a little puff of the pigtail? You can see the left coronary.
We do one more angiogram.
Yeah.
Okay. 照影可以吗？ What do you think? Is it too high or is it is acceptable?
我校正。
I think
For
the
self-expanding device, most challenging is the second shaping. When you totally release, so the left side will be up, and the non-coronary side will be down a little bit. So this is very hard to evaluate. What is the end stage of shape?
Yeah.
So this is for self-expanding device. This is a big challenge.
I think the axis is different. What I mean is the is not parallel, not coaxial.
Can we see an LAO view? Same caudal, whatever.
Okay.
Just take a look at the
We can
left
show you
cusp.
everything.
Yeah, show the left
LAO.
cusp.
再低一点。
Quick left cusp.
I feel a little concerned about the height. Maybe,
Yeah.
which is maybe too high.
Yeah, I think for an evolute it will be too high, but take a picture.
你那个 3 mark alignment 不好。
Yeah, okay.
Yeah, yeah, need to align it a bit. Yeah.
Okay, so
Align.
just a minute.
一个 angle,
Yeah, it's not easy
big
to
angle
align it.
of the intensify projection.
Okay.
不好意思。
The 3 dots help.
I said it should be okay. The
Yeah.
height should be okay. Too high.
Nothing too high on the.
Too high. The left coronary looks
Above the annulus.
You cannot judge the non-coronary side on this one, but on the other view, on
Yeah.
the cusp overlap, it looks a little high already. So I would say that maybe should go a little bit.
Depending on
Down.
the anchoring force,
Yeah.
supraannular structure anchoring force. So but not so many, but we still see some patients, we need to have a very high deployment
Yeah.
above the annulus.
Yeah.
Yeah, 这里可能是
On the left coronary side is already deep. On the non-coronary side, the coronary side is a little high, even above 1 millimeter above the annular.
yeah.
The second shaping, we don't know what is going on. Regularly, the left side will be up further, and the non-coronary side will be down a little bit. But it's a challenge to make correct judgment. What do you think? We can vote. How many support retrieve the device a little deeper, or how many agree to release it?
Personally, I'd like to the retrieve it and retry it. The reason why is first of all the current position is too high, and after the deploy the valve, because of the severe calcium, we have to be the additional balloon dilation. At that time, the possibility of the migration of the might be more
pumping
higher.
up. OK，我始终 alignment 不是很好，我往前推一点 push。Hi, Alan.
Yeah, I favor retrieval as well.
This is your
Go a little
okay.
deeper. Go not too much deeper, but a little, maybe a few millimeters deeper.
Okay, I agree with your suggestion. For me, my choice is to retrieve this time. 不用去擦了，这种产品用，看钙化就行。
好。
但是你在 alignment 上3个 mark 没 alignment，
这个很难打。
收吧。
Considering the severity or the amount of the calcium is very heavier, so there is the possibility of the additional balloon after the valve deployment. We think we have to consider that. So too much pay attention to the higher implantation.
顶到边上就毛起来，好的。现在顶不下去，你要缩小，再往里插。
Anyhow, this case is a really tough and high risk TAVR procedure case. Agree.
现在下去了。
对。
现在血压怎么样？升压。
对。
我们再插一下，现在太高了，太低了。
对，现在太低了。
我们再试看。你再放。
OK。
看啊。下限在哪呢？等一下，别动。我先冒个烟啊。
好的。有点
还是太高了。有点高。好。好，就这样吧。
好的。
好，释放，起搏吧。起搏130，干脆去起搏。A little bit hard to control.
Yeah, it's a challenging case.
Challenging case. 怎么说的？深就深嘛。下去了。
Better than the previous trial.
So. Too deep.
No.
Let's see.
放，再放。
Retrieving.
再放。
又下去了。
没办法，先上放再说吧。
我觉得先收回来，现在血压动就还可以啊。
Too deep. 再上，
好，
再放，
差不多啊。
没有高了，
稍微拉了一点点，拉了一点点，
我拉了，
拉了一点点，
就拉不住了。挺起搏吧 ，too deep， 挺起搏。very hard to control。
Yeah.
先让它血压先回去。
This is very
Too deep.
case.
Too deep.
Yeah.
If it is available, could you show us the angiogram? How deep it is?
You know, obviously, the height now is too deep. So the AV conduction has disturbance, and also the
Yes. Too deep. Agree.
totally good.
等它深一点反而就少。
你觉得还是深呢？我觉得还是要深。
太深了。
Too deep. We try to get it high.
Yeah.
OK. 起搏吗？
起搏啊。
你起搏吧。
So using the venous A plus, how many times can you retrieve? 3 or 4?
Fully retrieve once.
Fully retrievable maybe once.
不要拉太多，等会它一下子就弹出来了。
拉不上去了，这样拉。
等会，我说的还不够。现在差不多。
上。
那你拉了一点
再放，还是会往下走，要么就扇上去，往下走，就这样吧，高就高一点。
好，
但是你 alignment 不好 ，3 mark 的 alignment 不好，引起搏。
Right. Coaxiality is not
alignment
correct.
is not good. We can see the 3 marks are not aligned very well.
See a fair amount of tension in the catheter, see, isn't it? In the lesser curve of the aorta as well. So
往里推一点，
可以推一点。好，可以推一点点。 还好，这个位置还可以。
Maybe just check that and see what it looks like.
这个位置很难打。
Very hard to have a very good projection of X-ray.
Yeah.
Very hard to achieve a good projection. Very challenging case.
This is good. That's
Oh, now it's better. I
that's
think.
good. That's
Yeah,
good.
that's better.
That's good.
This is a bicuspid view.
Yeah.
Similar, close to the bicuspid view. Oh,
Yeah.
closer to the
他走了。
cusp overlap view.
Yeah.
Okay. One more angiogram.
Yeah.
传导主持已经说。Okay, good. It's okay.
I think it's okay.
The gauge,
Much better.
the gauge is not much better because we will have a second adjustment of the position. So regularly, the spontaneous adjustment is good for sealing the annula. So in most cases, after spontaneous adjustment, the leaking will be decreased significantly.
Okay.
So what do you think? We fully release it?
It looks good on the non-coronary side. Are you
That's
comfortable with the
something
left
to
side,
do.
or you want to check the left side? Are you comfortable?
Okay. 那它还会调整一下它的上
So
Left
move
side.
to the LL view.
Yeah.
Okay. So just a minute.
You can release on this view too. That's good. Yeah.
This is the LL view.
Yeah.
That's right.
Yeah, LL from right
但
here.
是你这边不是最低点，你这个 cusp overlap，这个 the non-coronary sinus is not the lowest one.
Yeah.
那它还会 spontaneous
Yeah.
adjustment.
Because you have a lot of tension. Hopefully, will lay over the other side, right, to the greater.
I already released the
Yeah.
tension. I already
Push it
push
already, yeah.
forward a little.
Okay.
So actually, at this view, the non-coronary sinus, the lowest point is not we don't have the lowest point of non-coronary sinus
Yeah.
at this view. I think it's acceptable.
Yeah.
So we already retrieved several times. I worry about.
Yeah. And you try release it and see how it looks like.
什么？那它会矫正的。
从这里开始，这边是5冠多。
It's okay on here.
So Dr. Liu, would like to one more retrieving.
Yeah, I just worry about it too lower. So is that
You know,
possible?
we have totally we have 3 times releasing now. The first time you think it's too high.
Yeah.
The second time you think it's too low. But now the height is between the first one and the third one. Okay. So if we want to higher a little bit, may not be
Okay.
controllable. Maybe go back to the first time.
Yeah, maybe.
You have to accept.
Yeah.
So do you want to retrieve and go for higher? Is that what you want to do?
Yeah. So what do you think? How about the panelists' opinion about that?
I think the current position is much better than the previous 2 trial, and even though there is the depth in the left coronary cusp might be deeper, agree. But too much the trial during a valve deployment, it is dangerous to the patient. So I think it's 3 attempt is quite enough. You know, the perfection is the enemy. So in the current situation, we are satisfied in this result.
Hi, Alan. What is your suggestion?
I would release it at this point.
Okay. What do you think?
Yeah, I
will
think,
take
To you
it.
guys, of
yeah.
course, because you guys have more experience. But certainly, if you want to retrieve, you can. You know.
Okay, one more time. One more time, Richard.
Sure.
Yeah, so because it's
Actually, I have
we have one
I,
chance.
for me, I tried
one more
one more
time.
time because
more time.
left
Try
side
again.
is too deep, and then it can be interrupt mitral inflow, the mitral valve. So I think one more try, then a little bit higher position was better.
If
now
you
we
try
are-
to the one more trial, and at that time, completely retrieval whole valve, and you manipulate the coaxiality before introduce the aortic valve. You know,
Good job.
in the current axis is
Yes.
just from the upside to the down, but it is not parallel to the ascending aorta.
You know, we actually every time we try to have a best
Coaxial.
alignment, we try to have a best correlation.
Yeah.
But it's very hard, you know. This kind of patients, very hard to achieve the optimal.
我等会我可以导师顶一点。
And
We can try that. We
and-
can try that, but it's very hard.
and
Okay,
such kind of
one more.
Yeah.
This is the
situation.
last time retrieve.
Okay, last time.
Last time we cannot retrieve too many.
A little bit higher. Too many
Okay.
bit higher.
Yeah.
It's good.
Sure.
Maybe go back to the first position. Okay, starting pacing 是130。
给我稍微顶一点，
顶也未必让他们顶得太深了。
慢慢收
他。建议你全部收回来，我觉得是对的，不要搞一半。
就我觉得稍微顶一点就可以了。那你看现在他马上就上来一点点，还没完，
他才
直接
下
上来了。那他上来了，你看他是那个黑色的 mark 点，他已经上来了，那已经上来了，再
还要再上，
收一点点啊，
还要再上
收一点点啊，，
还要再上一
那
点，
已经上来了，
差不多。
差不多啊。你现在的
我拉不住了，已经。
我现在你拉了一点，我觉得现在可以啊。那现在明显比前面好一点。
又下去了。
你起吧。
挺起吧。I don't think I have the position has much change. It's quite similar to last one. Quite similar to last one. 也很难了，你要 totally release 才能可以。差不多。
If the run request, if you want to push it, you have to push it down to push it across. Otherwise, it's too short.
这你没达到他那个，
对，
就是叫什么？我都 forget the word。这个没差点，
对，
It's
或者
about
我
the
们多
same.
收一点，
Yeah.
再上来一点。
你再搞就
好的
不太好了。你要么就下决心就收回一次，我们放个位置，重新低就低，高就高了。你这样犹豫，反正那个。
好，对
OK 起步，
好来，
那你收，
好
你收，
OK
你收全部收回来，
好，
再收一次就上。
对，我们再收一
So
次
you're。gonna retrieve it completely, right? So you retrieve
Yes,
completely.
yes.
Otherwise, you can't really, you kind of stuck in where you were.
去，你这到底，你不要犹豫，你别犹豫。好，
等一
Okay.
下不要顶了，往外拉一点点
是，
往外拉一点点，他往外拉一点点。好，
Yeah, I think pushing the I don't run request is stiff, but pushing a bit maybe help you to be more coaxial.
Before introducing your valve,
顶起步，
clockwise rotation and make the coaxiality of the valve clockwise more and more.
这前面张力不要太高。
或者我们就换一个版本，换一个版本。
We would like to change your device. You know, we already retrieve several times. We are worried about the. 因为 already. 啊，你当时不要顶，当时不要顶，
好
拉回去，哎，当时出来的，退出来，重新换一个板上，这样安全点。
So change the valve.
You know, we already retrieved several times. We are worried about the. 犹豫，你想搞一半，反而搞不了。
I have a suggestion for the wire position. So already Dr. Hong already mentioned about the wire position because the wire should be, I think, laid down to the great side of the aorta that helps to make a coaxiality. So if you are trying to next time, I think the wire should be go directed to the posterior, so it can be make a more horizontal position to deliver the THV system.
第一次是可以的，
对，其实第一次是比较好
第。一次和第二次之间可能就很难。
啊，
但是生了。
That was very vertical, and then during the deploying the half deployment of the valve, the system foreshortened to the less curvature of the aortic arches, so that can be make a pop up of the system after deployment.
The AV conduction comes back.
Okay.
The cover comes back.
We don't.
Getting the cover.
And blood pressure is okay. 120 over.
Yes.
30.
Okay.
Yeah, that's stable, yes.
Diastole is a little low. But the systolic is okay.
In the fluoroscopic, could you show us the fluoroscopic image?
Yeah.
One of the
can
valve
see
is
the
the
calcification.
swing is a very wide
Yes.
range,
Yes. The calcification. Yes.
Very mobile.
mobile.
Yes.
这个斑看得特别白，首先它已经有 regurgitation。
It means that Dr. Wang is select a very high risk patient. We really appreciate this is a very real life demonstration for the tough cases of the TAVR.
So the patient now may have a severe regurgitation. So you can say the valve is already.
Yeah. The
可
calcification
能我们
is
这次
moving.
就放，刚才
Yeah.
If you're concerned, you can pace the patient a little bit higher rate, so decrease the diastole.
But now the
Pressure's okay, right? So-
hemodynamic is quite stable.
Yeah, yeah.
So should be okay
Yeah.
without the pacing.
Fortunately, the favorable hemodynamics might be at the young age of the patient. If the patient age is more than 80,
时间是在 possible overlap.
this kind of situation may not be tolerated.
Alignment 挺难。
possible overlap 就行了。
诸位先进，我把它
这几个人我们就耽误时间了。然后你只能一次就到什么什么就什么什么，不能再。其实第一次是可以的，
对，我觉得第一次最好
第。一次其实那你再回过头来就，那第一次也可能随便弹出来的。
Alan, I have a question to you.
Yeah.
So, if there is no
That's all
other
it is.
option to
Yeah, but
choose the
the
wire, so if you are trying to use this kind of round cast wire during the TAVR procedure, have you make some curve at the end of the?
Yeah, if I use a London, which I don't use that often, is really make the tip really a pigtail,
Yeah.
and trying to bury a little bit stiffer part of the aorta around the arch, so that would track across. Because if you leave a soft part, it just kind of becomes a straight wire down.
Yeah.
So I like to have it bent a bit and follow that curve. For example, like try to bury it pretty deep in this picture and not hanging out high.
Yeah.
中间也是因为很切割的。
So this is a better position, for example.
Yes.
会不会他把这半叶掀起来以后啊，会不会26不够大？对，原来是有腰的，现在
我觉得你今天这个病人，如果你还用29的话，你29，你刚才用29就已经这么大的力往下转了。
现在我说现在
要再有力了，大概操作次数不宜太多，第一次刚好那个。
对，第一次很好，对。
So,
3也是。
so you like to go back to the high version, right? The three versions. You like to go to the high version and see what that looks like.
Yes, we still we expect a little higher deployment. It is better a little lower than the first time, but higher than the last time.
Yeah.
But it is not so easy to achieve the height. Maybe still go back to the first time or
Yeah.
go back to the last time.
As you said, sometimes the final position is a little different by a few millimeters. It's hard to
Especially
predict
for
that.
the self-expanding.
Yeah, hard to predict that, right? So once you release the the non-side would come down a little bit, the left side would go up a little bit, but exactly how much is a little difficult to predict.
Yes. Actually, it is a weakness point for self-expanding.
Yeah.
After you totally release the device, it will have second shaping, which is totally different from the balloon expandable.
Yeah. Dr. Wang, so we're going to start a short lecture, and then we can just come right back to you.
Oh, you're welcome.
Is that okay?
You're welcome.
Okay, all right. We'll be right back.
Good.
So
Okay, good.
let's start with a lecture by Jinming. Jinming's here. I can see him running up here.
一次释放也许后面会跳上来。
Jinming is going to talk
也许
about
第一次呢，
TAVR
太
for
高，
bicuspid
太高。
valve,
第二次
practical
呢，
tips and
你
tricks
看啊，
for
第一次
optimum
呢，
sizing and positioning. So
很难控制。
very timely lecture
完
for
全
this case.
第一次呢是自求。
So, thank you, Alan. My topic is TAVR for bicuspid valve. I thought that the balloon expandable valve will be covered by the Dr. Wang, so I'd like to focus on the balloon expandable valve only, not self-expandable valve.
Okay.
So it's very ironic that the first TAVR was done in bicuspid valve by Alain Clivier 20 years ago. But many trials, bicuspid valve was excluded because of very difficulty for TAVR treatment. But recently we have some registry data. SAPIEN 3 data show that the no significant difference between the bicuspid valve disease, tricuspid valve disease, between mortality and stroke, and Everett R data show that the similar outcomes. All-cause mortality, there is no difference between the bicuspid and tricuspid valve disease. So which valve would be better than the other? SAPIEN 3 or Everett R for the self-expandable device? We don't have any comparative randomized trial, but we have only small observational data. In bicuspid TAVR registry show that the first generation SAPIEN XT and core valve system, regarding the mortality, there is no difference up to 2 years. The Vista registry, the Everett R or Everett 4 Pro, compared with the SAPIEN 3, regarding the hard endpoint, there is no difference. Balloon expandable device, self-expandable device in bicuspid valve disease. But complication profile is a huge different, as you can expect it that. Rupture of annulus rupture risk is higher in SAPIEN 3 system. The rupture risk is 1.7, but Everett system, no risk of rupture. But at least significant parabolic leakage, moderate to severe. SAPIEN 3 is only 0.8, but Everett R is almost 10%. So overall hard endpoint regarding the death and stroke rate, there is no difference between the two devices, self-expandable, balloon expandable, but different complication, the profiles. Higher risk of aortic rupture in balloon expandable device, but the higher risk of parabolic leakage in self-expandable device. How to decide the device sizing, that is very important. We have lots of sizing algorithm. Dr. Wang suggested us that the balloon sizing for self-expandable device. But I think this idea is very important from the Barbado registry, show that he evaluated the bicuspid aortic valve shape, the intercommissural distance and aortic annulus distance. If the intercommissural distance is larger than aortic annulus, they call it the flare type, smaller taper type, same tubular type. So if bicuspid aortic valve would be the frequently tapered type, we have to make a device sizing based on the supraannular structure. But based on the CT data from Barbado registry, the most bicuspid aortic valve, opposite to our idea, previous idea, tubular type, flare type composed of the almost 90%. Only 10% show that the taper type. So I believe that at least for the balloon expandable device, the conventional annular space sizing would be okay. So in our center, you can see, you can observe our second live demonstration 1 hour before. So balloon expandable SAPIEN 3, even though bicuspid aortic valve, we didn't consider the supraannular structure. Just based on the annular area, we decided the balloon expandable device size. But important thing is don't do oversizing. Less than 5% would be safe. But supraannular sizing may be applied to the self-expandable device. Lots of algorithm, but we need more evaluation. So balloon valvuloplasty before device delivery in post-tricuspid aortic valve, it is not routine, but in bicuspid aortic valve disease, balloon valvuloplasty is more frequently performed because heavy calcification. What is the goal of balloon valvuloplasty in bicuspid aortic valve? The first goal is facilitate device delivery, and second goal is device sizing, the Dr. Wang's case, and access the risk of coronary obstruction, particularly in case of a chunk calcification around the left coronary, right coronary ostium. But we have to know that to avoid the risk of aortic complex injury, relatively small balloon should be selected based on the CT measurement. So balloon size should be smaller than minimal diameter of annulus based on the CT. After introduction of SAPIEN 3 in our center 2016, we predominantly implanted the SAPIEN 3 even in the bicuspid aortic valve disease. Between the 2016 to 2012 we performed the TAVR in bicuspid aortic valve, 89 patients. This is age proportion of TAVR in bicuspid AS. As you can expect that older age, low incidence of bicuspid AS, the younger population, higher incidence of bicuspid aortic valve disease. In overall, in our population, 11.5% of patients have bicuspid aortic valve disease treated by TAVR in our as a medical center. This is a proportion of TAVR for bicuspid aortic valve disease. Between the 65 to the 70, half of patient aortic valve disease is bicuspid aortic valve. But typical TAVR age, more than 81, 90, less than 10%, 5 to 6% of incidence of bicuspid aortic valve disease. So typical type of bicuspid aortic valve, our registry data show that the type 1 is 76, type 0 is only 24. So bicuspid aortic valve type, similar to the Barbadi registry, 92% of bicuspid aortic valve has a tubular type or flare type. So for device selection in balloon expandable device, we can depend on the annulus size only, done without consideration of the supraannular structure. This is a baseline characteristic between bicuspid AS and tricuspid AS. Younger population in bicuspid AS, accordingly low risk of comorbidity. The CT measurement has a very different between the bicuspid AS and tricuspid AS. The annulus area and perimeter is bigger, STJ, LVOT area is bigger, left main height, ICA height is higher in bicuspid AS. So calcification is very important in the bicuspid aortic valve disease. Previously, Dr. Yun published that the calcification location and amount is associated with long-term mortality. Severe valve calcification has a higher risk of aortic root injury and higher risk of paravalvular leakage. The very rare low calcification volume, like our live demonstration case, I think the low risk of TAVR, but severe asymmetric calcification or LAFEC calcification, severe calcification extending to the LVOT may have the higher risk. The most important thing is the calcification volume in bicuspid aortic valve. In our center, tricuspid aortic valve, mean volume of calcium is only 400, but bicuspid aortic valve mean volume is 600. So basically, bicuspid aortic valve disease have a twofold higher calcification volume compared with the tricuspid aortic valve. So how to decide the SAPIEN 3 device sizing? According to the calcification, the severe calcification in tricuspid aortic valve, we didn't do much oversizing. In bicuspid AS and heavy calcification, nominal sizing or at most less than 5% is our initial device sizing. Look at I analyzed our registry data show that how much we oversized in the bicuspid aortic valve TAVR, almost overall only 5% oversizing. According to the calcification volume, severe calcification volume is more than 1,000. Only nominal size. Calcification is less than 400, almost 8% oversizing. This is, I think, very important. This is the case, 79 male bicuspid AS, annulus area is 589, severe calcification, asymmetric, only 2% oversizing. Final result is acceptable. And 79 bicuspid AS, annulus area is 500, very severe aortic valve calcification, 1,300, one of the extreme case. So undersizing for 4%, even 4% undersizing, 96. Final angio is very acceptable, no leakage, very safe. So 83, 710 square millimeter, very big annulus. Calcification is 800, 9% undersizing, even though acceptable range of PVL and no risk of annulus rupture. So in calcified bicuspid aortic valve disease, particularly calcification is very severe, nominal sizing, initial undersizing, volume expandable device sizing would be safe and safe and very effective. Anyway, don't do oversizing in SAPIEN 3, less than 5%. This is the procedural outcome. Valvuloplasty is more common in bicuspid AS, and even though there is no difference regarding death and stroke rate between the tricuspid and bicuspid. This is my final slide. What is optimal TAVR by balloon expandable device for bicuspid AS? Actually, we need more data. Case selection is very important. I don't like to say a very extreme case of every case of bicuspid AS can be treated by the TAVR, but if we can select the good candidate for TAVR, I believe we can do TAVR. We can do TAVR for bicuspid aortic valve disease. Incidence of PVL is increasing compared with tricuspid aortic valve disease, particularly when you treat the bicuspid aortic valve disease by the self-expandable device. Aortic injury should be cautious. However, TAVR for bicuspid AS is not associated with excess risk of mortality or stroke. SAPIEN 3 implantation on bicuspid aortic valve is not generally different from SAPIEN 3 implantation on tricuspid aortic valve, but don't do oversizing and depend on the severity of calcification. Thank you for your attention.
Let's move to the next presentation. The next topic is a balloon expandable versus self-expandable TAVR for the TAVR valve. When or how? The presenter is James Flaherty from the United States. James, please.
Good afternoon. Thank you very much. I'm going to expand a little bit on what Dr. Ahn just covered. I have nothing to disclose. He covered some of this stuff, some of the unique features about the bicuspid aortic valve and how to incorporate that in your decision making. So we know that it's the most common congenital heart defect, up to 2% of people. And younger patients who have severe aortic stenosis tend to be more commonly bicuspid. In the U.S., it's about 5% of TAVR, so in some Asian populations, it tends to seem to be a little higher than that for the TAVR patients. And you can see here that in the younger, is defined by less than 70, bicuspid is much more common morphology by this pathology study. We all know the Sieverts classification, which bases on the number of RFA 0, 1, or 2. and 80 to 90% are Sieverts 1. And here's some illustrative examples of that with the RAFAs and the fused calcium. The anatomy, as Dr. Ahn touched on, is critically important and the big distinguisher between bicuspid and trileaflet aortic stenosis. There's a lot of differences, patterns of calcification, amount of calcification. The aortas tend to be more horizontal. So it's really important to study this anatomy to avoid risks. So is TAVR better than TAVR? There's not a lot of trials on this. And all the pivotal trials on TAVR didn't excluded bicuspids. And so we're limited to observational registry data. Here's some registry data from the National Inpatient Sample in the United States looking at surgery versus TAVR for bicuspid. And you can see that the trends, like most treatment of aortic stenosis for TAVR, has gone through the roof. In this matched analysis, there was a little bit of a signal of worse outcomes with respect to death for those that are under 65, and a little more complete heart block. The heart block you can certainly understand. The death thing, it's hypothesis generated, but it's important to understand because young patients are often very low risk for surgery and get excellent results. What about TAVR? Is it safe? We know the early experiences was touched upon, had some issues with the early devices, more annular injury, conversion to surgeries, more leaks, leading to second valve implants, more pacemakers, signals of increased stroke. So the first generation devices were not perfect, and Dr. Ahn touched on the different morphology and fused raphe and calcium patterns that directly correlate with mortality if you have two fused raphe that are calcified, and the degree of paravalvular leak. So your calcium and raphe patterns do impact outcomes. Dr. McCarr out of Cedars looked at the STS registry comparing bicuspid versus tricuspid TAVR and really didn't see a whole lot of difference, at least in this matched group, in terms of death or stroke, although there was a tiny signal that there was more stroke, and that's a signal that you see in a lot of these observational studies. However, when the group then looked just at the low-risk group, that signal disappeared, and there was actually a slight trend towards worse mortality in tricuspid. All this is hypothesis generated, and it's just registry data, but it really informs our thought on a lot of this. So in whom was surgery preferable? Certainly if there's a significant aneurysm that can only be addressed by surgery. Our guidelines prefer patients that are less than 65. Certainly less than 50 might still get a mechanical valve. You have to consider if they're young, what's their next option going to be? If they're not going to have a good TAV and TAV option, then maybe surgery is the preferred first treatment. Aortic regurgitation should only be done if there's enough calcium to anchor a TAVR valve. And then there's that high procedural risk that Dr. Ahn was touching on, the severe LVOT or bulky asymmetrical leaflet or raphe calcification has to be considered before just running into a TAVR. These are two recent registries. These are not comparative, but they're informative. One looking at the self-expanding valve, the Evolut, and the other looking at SAPIEN 3. And they both enrolled about 150 to 200 patients. Very similar patients, 70 years old, about a little less than half female, about 90% Sievers 1, low STS score. So similar looking registries. Importantly, only about 50 to 70% of patients who were screened got in the registry. So when you look at bicuspid data, it's highly selective. So Dr. Grube was mentioning, should we have randomized controlled trial? Only if we're going to enroll all the patients, which clinicians seem unwilling to do. But here's the data from these registries. This is the most contemporary data we have. 30-day data with the self-expanding, really pretty good. Death, 0.7%. A little bit of a signal on stroke, and of course pacemakers, a little higher with the self-expanding, but great results on AI with almost nothing more than mild. And over here on the balloon expandable SAPIEN, really low death, stroke, pacemaker rates, so really looking a lot like the experience with tricuspid aortic stenosis. And here's some of the hemodynamic data. The self-expanding valve consistently leads to a lower gradient compared to the balloon expanding. The long-term implication of that is not fully understood. And in this analysis on the SAPIEN, they compared groups with tricuspid and bicuspid, and in terms of the hemodynamic response, through a year, it really was identical. Special considerations, especially the young patients. This is a really important issue with bicuspids. Higher risk of pacemaker and long-term that can have implications. Coronary reaccess is a big issue in the younger patients. Those that don't have minimal dilation still have to be followed. You can't forget about the aorta entirely if it didn't meet an indication for an operation. And then this theme has come up over the day, the lifetime management. In a young patient, right now we don't have the technology that was alluded to earlier, but if you think someone's going to need at least one more valve, what's your strategy? SAVR then TAVR, TAV and TAV, or valve and valve TAVR. So it's not fully worked out. In terms of coronary reaccess, the things that make it challenging are very narrow sinuses, a higher implant of a TAVR valve, and the self-expanding in this analysis had a much higher rate of difficulty reaccessing the coronaries. What about just explaining the valve and putting a surgical valve in? Well, here's an experience of about 300 patients. And if you see, they have about a 12% inpatient mortality risk. And here's some pictures of how difficult these surgeries can be. And the one-year data is really terrible, 30% death rate and 20% stroke rate. Now, this is a selective group that had something wrong like endocarditis or early valve failure, but still, we can't just assume that reoperation is going to be the way to go if you do a TAVR and a bicuspid that doesn't have ideal anatomy for a TAV and TAV in the future. Here's some new concepts that are going to become important, especially for supraannular valves and coronary reaccess and the prospect of TAV and TAV, looking at the geometry of the coronary arteries and also looking at the radiological markers for the commissure posts so that you can align the valves so that you have commissure alignment. This is going to be increasingly important as these techniques are refined, both for coronary reaccess and for TAV and TAV. What about TAV and TAV? Here's an analysis looking at TAV and TAV, TAVR in a previous TAVR valve, or valve and valve TAVR, a TAVR valve and a surgical valve. And in this analysis that was matched, really patients did quite similarly with procedural success and complications. Not surprisingly, a TAV and TAV in general leads to a lower gradient than a valve and valve TAVR in a surgical valve because that surgical valve can be constraining. Now, this didn't necessarily use techniques like fracturing the valve. So really it's just observational. What about outcomes for TAV and TAV based on valve type? Well, as I said earlier, in general, the self-expanding is going to lead to better gradient profile. Now here's a graph based on the first valve choice, whether it's balloon expanding or self-expanding. And really they did quite similarly. It says 70% success, but success means perfect. Really the mortality rates were really low. So in selective anatomies, TAV and TAV can be done safely and effectively. Slight signal of higher gradient with the balloon expandable, but not significant. What about second valve choice? This is first valve choice, this is second. And this showed, not surprisingly, similar procedural results, but a higher chance of a high gradient with a balloon expandable valve. The caveat here is the anatomy has to be able to accommodate the TAV and TAV. And you have to make that decision the first time, not later on. So in conclusion, current generation valves have emerged as a viable solution for bicuspid aortic stenosis in many patients. Prior to doing this, though, you have to pay careful attention to the specific anatomical risk in the aorta. The decision between TAVR and SAVR really has several factors, including life expectancy and anticipated future valve implantation. And the decision between balloon expanding and self-expanding, they both work well in selective anatomies, but the choice may depend on what may happen downstream, including coronary reaccess and the prospect of TAV and TAV. Thank you.
Very nice and very excellent summary. Sorry for the skip the discussion of the for two presentation. We have to back to the live cases. We want to see the final result of. Okay, Dr. Wang.
Hi, thank you, all of moderator and panelists. We already finished the procedure. Could you see the
Yeah.
the fluoro
Yeah.
fluoro screen?
Yes.
Keep going.
Yes, we change a new device, same size, 26. So we successfully get device in. We try to achieve optimal position. This time looks okay. So the height is quite optimal. Then it's very hard to have a very good projection, but we still. Now we release the device. Keep on going. So we try to very hard to have a very good projection with a good alignment. But we at last on this view, we have a very good alignment of 3 marks. Then we totally release, and this view. So keep on going.
The final portion.
Now it's releasing now. So can you see? We are close to, now we totally release it. Then we try to get the device out. We did the post dilatation with the same balloon, 23 balloons. So after post dilatation, we measured. Here's the last shot. You can see only mild regurgitation. Also, we did the echocardiography. It's also a mild. Also mild aortic regurgitation. The pressure gradient is almost gone. Can you see that? You can see the hemodynamic screen now.
Screen, yeah.
So you can see the pressure gradient only 3, right?
Yes.
But before the
180.
procedure,
180.
it's a 180, almost 200. So now, I think possibly this is the most optimal result for this kind of so challenging case.
Right, very, very nice. I mean, I think
Any
this
comments?
this position, as you said, you want to be a little higher than our final position with the third deployment of the last valve, right? This is higher than the third deployment. So this is what you want to have. And do you have the picture on the left side or on the left corner? How in the final position?
Okay. Yes. We try to show you
illustrate
the
us
left side,
how it released. Yeah.
left side the fluoro.
Yes.
你现在还可以的哦。Okay.
Yeah.
This is the left side.
Yeah. Looks quite good. It seems like this time the catheter is more on the outer curvature of the aorta than the last time.
Yes, we push the device a lot. We keep the force pushing forward of the device during the releasing. You know we so worried about the pumping out, pumped out of the device. So we keep the tension, pushing the device forward while we are releasing.
Yeah.
Very excellent result. Really appreciate your skill and the very tough cases live demonstration. We really appreciate. Thank you.
Great job. Thank you.
Thank you.
Thank
you
See
so
you
much
soon.
for your
Yeah.
comment.
Thank you.
We are learning a lot. Thank you.
Thank you.
Bye-bye.
So hopefully see you next time and see you on
See you very
site.
soon.
See you in person.
Okay. Thank you.
You're
So
welcome to
we'll
China
wrap up
and,
this session.
welcome
Thank you
to
very much.
Hangzhou.